What is Ludwig angina? Ludwig angina is a bacterial cellulitis involving the soft tissue of the floor of the mouth and also the neck. To understand better on the extension of the infection, let's look at the anatomy of head and neck. Ludwig angina is an infection which will spread into the submandibular space. Submandibular space lies between mucous membrane of the floor of mouth and tongue on one side and superficial layer of the cervical fascia extending between hyoid bone and mandible on the other. It is divided into two compartments by the mylohyoid muscle. The first one is sublingual compartment, which lies above the mylohyoid muscle, shown by a red arrow, and the second one is submaxillary and submental compartment, which lies below the mylohyoid muscle, shown by the yellow arrow. These two compartments are continuous around the posterior border of mylohyoid muscle. When there is a cellulitis, it will displace the tongue superiorly and posteriorly, causing an airway obstruction. For epidemiology, there is no gender predilection for Ludwig angina. The mortality rate is approximately 8%. 1 out of 3 cases are associated with other systemic illnesses such as immunocompromised condition in HIV infection and diabetes, poor dentition and dental hygiene.
Moving on to the pathophysiology, Ludwig angina happens when there is infections of the teeth, particularly second and third mandibular molar, which latter forming an abscess and dental infection that can extend towards submaxillary space and towards sublingual space, which can encircling and causing obstruction to the airway. The etiologies that cause Ludwig angina are dental infection, dental caries, submandibular sialadenitis, fractures of mandible, and the bacteria that cause Ludwig angina includes alpha hemolytic streptococci, staphylococci, and Bacteroides groups are common.
Patients with Ludwig's angina may complain of otorhinophagia, dental pain, neck pain, dyspnea, muffled voice, and symptoms of infection such as fever, malaise, chills, and generalized weakness. The signs that can be elicited during physical examination are trismus, also known as lockjaw, a swollen and tender neck, raised floor of mouth, drooling of saliva, which may indicate otorhinophagia, and stertor, which is a noisy breathing due to oropharyngeal obstruction.
Ludwig's angina is diagnosed clinically. Investigations that can aid diagnosis are blood cultures to determine if there is a hematogenous spread of infection, a CT scan of the neck with IV contrast to evaluate the severity of the infection and assess for any abscess. Lastly, neck and chest x-rays to demonstrate gas in the tissues in the case of infections caused by anaerobic microflora.
Initial management of the Ludwig angina involves admission of patient to the high dependency unit and assess the patient as soon as possible. The most critical part of the assessment is the airway, as the asphyxiation from the airway obstruction is the major cause of death. Secure the airway immediately by delivering oxygen through the nasal prong and nasal intubation. Subsequently, monitor the patient closely for any complications. The initiation of the intravenous broad-spectrum antibiotics is the first-line treatment once the airway is secured to control the spread of the infections. Intraoral incision and drainage of the abscess is indicated if the infection is localized to the sublingual space, and extraoral if the infection involves the submaxillary space. Emergency tracheostomy should be performed in case of acute airway obstructions. In terms of complication, Ludwig angina can cause airway obstruction due to the raised flow of mouth and pushing back of tongue. Infection can spread to the parapharyngeal and the retropharyngeal space and subsequently to the mediastinum. Septicemia can occur as the infection spreads through the blood to all parts of the body, and lastly, it may evolve to aspiration pneumonia.
So as a take-home message, Ludwig angina is a life-threatening cellulitis of soft tissue involving floor of mouth and neck. The infection can progress rapidly into potential airway obstruction, which is an emergency. The first step of management is to secure airway, followed by giving broad-spectrum antibiotic intravenously.